So today we'll begin a simple primary care review on constipation in elders. Constipation is a common complaint in older adults. Functional constipation is defined as any two of the following features: straining, lumpy hard stools, sensation of incomplete evacuation, and decrease in stool frequency, which is less than 3 bowel movements per week. The above criteria must be fulfilled for the last 3 months, with symptom onset 6 months prior to diagnosis. Primary causes: slow transit constipation. Slow transit constipation is due to a primary dysfunction of colonic myopathy or neuropathy. Dysenergic defecation. Dysenergic defecation is caused by a difficulty with bowel movement or inability to expel stool from the anorectum. Irritable bowel syndrome. Irritable bowel syndrome comes with predominant constipation. Secondary causes. Secondary causes associated with constipation include endocrine or metabolic disorders, neurologic disorders such as Parkinson's disease and stroke, myogenic disorders and medications, and opioid induced constipation is common in those suffering from chronic or cancer related pain. Idiopathic causes. Chronic idiopathic constipation or functional constipation is defined as the infrequent, persistently difficult passage of stools or seemingly incomplete defecation, which does not meet IBS criteria. These patients usually do not have any physiological abnormality. Physical examination. A rectal exam to palpate for hard stool, assess for masses, anal fissures, hemorrhoids, sphincter tone, and push effort during attempted defecation would be necessary. Prostatic hypertrophy in males, and posterior vaginal masses in females. For laboratory testing, you would need a comprehensive metabolic panel, a complete blood count, and thyroid function tests. Management. 1. The first step is lifestyle and dietary modification. 2. Bulk laxatives are recommended in patients who do not respond to lifestyle and dietary modification. 3. Osmotic laxatives should be considered in patients not responding to bulk laxatives. 4. Colon secretagogues should be considered in patients who fail a trial of osmotic laxatives. 5. Stimulant laxatives are efficacious, but chronic use should be avoided, as the long-term safety in older adults is not known. Enemas should be only used to prevent fecal impaction in patients with several days of constipation. 7. In patients with dysenergic defecation, biofeedback therapy may be helpful. Fecal impaction. Fecal impaction results from the person's inability to sense and respond to the presence of stool in the rectum. Decreased mobility and lowered sensory perception are common causes of fecal impaction. Diagnosis of fecal impaction. The diagnosis of fecal impaction is confirmed by performing a digital rectal examination. The key to the diagnosis of fecal impaction is in finding a copious amount of stool in the rectum. Fecal impactions can occur in the proximal rectum or sigmoid colon. If the clinical suspicion for a fecal impaction is high, an abdominal radiograph should be obtained to detect fecal loading in the absence of a rectal impaction. Fecal impaction management. Digital disimpaction to fragment a large fecal bolus to facilitate its passage through the anal canal would be necessary. Subsequently, a warm water enema with mineral oil may be administered to soften the impaction and assist emptying of stool from the rectum and distal colon. Once the distal colon has been partially emptied with disimpaction and enemas, polyethylene glycol may be administered orally or by a nasogastric tube. Thank you.